Well, welcome everybody. Thank you so much for being with us. We really appreciate, number one, your time and also your interest for this informative session with Dr. Mark Eltis. Before we get into his presentation, I'm just going to do a quick introduction of both of us and then just an overview of this evening's schedule. So to start, my name is Kristen. I am the VP of Sales and Marketing for HEINE Canada. I've been with HEINE for 24 years. I might recognize some of you guys, or maybe you recognize me from the field. And I have the pleasure of introducing Dr. Mark Eltis. Mark and I have actually, we were just discussing, we would go way back to the Waterloo days. So I met Mark around 25 years ago when he started at Waterloo. So Mark is a Toronto OD. He practices downtown Toronto, but also practices or has practiced, outside of Canada in New York and California. Very big traveler, does lots of talks, lots of lectures, including Waterloo, but also at various conventions, and is also a legal and clinical consultant for many firms. So really happy to have you, Mark. Looking forward to your presentation this evening. It's gonna be super informative. So thank you. Before we start with Mark's presentation, I just want to give an overview of this evening. So of course we have Mark's presentation. At the end, I'm going to go over a few minutes with the Omega 600 itself and just talk about some of the key features. Then at the end, we'll have a little session of Q&A. So if you have any questions, please feel free to put in our chat box. We'll address those at the end of the presentations. So on that note, I'm going to pass the mic and the screen over to you, Mark, for your presentation. Thank you.
Well, thank you so much, Kristen, and it's a pleasure to be with everyone tonight. Thank you for making it. I know we've got some busy practitioners and students, so it's a real pleasure. I'm going to share my presentation now. Perfect. So just check, Kristen, you can see it, right? Perfect.
Yes. Yep.
Awesome. Great. So like I said, thank you for joining us. And I'm going to start clicking in here. Let's see. Perfect. So while retinal imaging has become an amazing tool for patient care, traditional techniques still play an important role. Courts have consistently ruled that retinal imaging is not a replacement for a dilated fundus exam. In fact, one of the major causes of litigation in eye care is a failure to dilate when indicated. Indications for dilation are, everybody knows what they are. It's myopia, history of flashes, floaters, retinal detachment, obviously, or a history of retinal detachment, diabetes, hypertension, among others. Now, dilation with associated instrumentation is still the gold standard for retinal examination. Practically speaking, dilation and imaging technology are best used in concert, and that's what I advocate for. We don't have to pick one or the other. With the increasing popularity of retinal imaging, some practitioners have unfortunately let down their guard in terms of DFE or dilated fundus examination, which leaves both doctors and patients vulnerable. Obviously, patients vulnerable to potential disease or complications, and doctors vulnerable to litigation. Now, imaging is wonderful, but it does have limitations. Remember that an OCT does not reach the retinal periphery, or most OCTs. Conventional fundus cameras do not reach the retinal periphery. Wide field digital cameras lose some of the true-to-life detail, and colors can be distorted with wide field imaging technology. Now, you still miss extreme periphery with even the most advanced wide field imaging to this date. There's no scleral indentation with imaging, no dynamic viewing, and stereoscopic viewing can be more challenging. Now, I really liked this article, and that's why I thought I'd share parts of it. I thought it was very comprehensive. And it says, how to be sued for malpractice. You don't want to dilate, you don't have time to document, you may be on your way to court. So more than 90% of cases against optometrists that allege misdiagnosis of intraocular disease involve failure to dilate the pupil. Dilation of the pupil is a necessary part of comprehensive examinations. It also helps clinicians to detect diseases like glaucoma, retinal detachment, tumors, the three causes of more than half of large malpractice claims brought against ODs. Liberal use of pupillary dilation is probably the single most important thing an OD can do to reduce the likelihood of misdiagnosis that results in a malpractice claim. Dilation of the pupil should always be used when patients are at risk of disease. For example, individuals with acute onset PVDs or individuals with diabetes. Dilation itself is an exceptionally rare cause of liability claims. I know a lot of practitioners worry about angle closure, and I tend to be very cautious too when I do gonioscopy if I'm ever worried, and I counsel patients. Every single patient that I dilate, I do counsel on the risks and benefits. But just as a relief, know that angle closure is quite rare with dilation. There can be slip and fall accidents that occur post-dilation, or patients that are upset if they weren't told that they're going to be blurrier or won't be able to read their phone, or that driving may be more challenging. So I always discuss that beforehand. I like to under-promise and over-deliver. So if patients say, oh, I'll be able to go back to work and do this and that, I tell them, well, it's possible you may not be able to, just so that they're not upset afterwards. You want to warn patients about everything, including the blur and reduced visual acuity. And of course, if you can have sunglasses for them or remind them to bring sunglasses to their examination just in case, that's also a plus. Elderly patients or patients with specific concerns may require more assistance once dilated, so you want to keep that in mind. Now, these are my 3 ways to avoid trouble in practice. Done a video on it, I think, on other social media channels, but dilation, documentation, and communication. So documentation is key in pretty much every legal standard that I know of. If you don't document it, you didn't do it. So it's absolutely essential that you document, explain to the patient about the risks and benefits of dilation, that you dilated and with what medication. And then communication is so important for many reasons, because even if a doctor is competent, if a patient doesn't feel that you care about them or that you didn't explain things, that you lose your credibility. So communication is key. And some research shows that even when a doctor makes a mistake or something happens which the patient isn't satisfied with, if the doctor is good at communicating, they're much less likely to take action. The patient is less likely to take action against that practitioner. Now, what are some of the causes of major financial awards? Retinal detachment, no surprise there. Precursors to retinal detachment, eye and brain tumors, choroidal neovascularization, glaucoma, and diabetic retinopathy. Again, probably not a surprise there, but interesting to list them out. Now, in one study, 85% of retinal detachment patients who were misdiagnosed did indeed present with risk factors for retinal detachment. So who is at risk and when is a DFE indicated? Posterior vitreous detachment, lattice degeneration, trauma, detachment in the fellow eye, cataract surgery, and myopia. And of course, this isn't a comprehensive list, but it's just to bring things to mind that you should be thinking about. Now, according to one expert, who is also the chair of the OMEGA board of directors and was at the time of the writing president-elect of the Academy of Ophthalmology, the exam should include confrontation visual fields. Again, even if you don't have a visual field machine, this is a good way to check. It's quick and easy. Assessing for the presence of a retinal relative, a afferent pupillary defect. Again, a very easy test, and everybody should be able to check pupils in their clinic. And inspecting the vitreous for hemorrhage, detachment, and pigmented cells. Of course, the vitreous, sometimes we forget about it as a structure to examine, but it's also a key part of the eye to look for clues that something more sinister is going on. Now, just comparing some of the techniques, remember that a 90 diopter lens requires a slit lamp. A BIO, although we don't think of it as a portable device, it is quite portable, and you could technically do it anywhere if you're doing exams in a hospital and other areas that aren't necessarily set up for eye exams. A BIO can easily be used. I know we always think of a direct ophthalmoscope, but a BIO is also very portable, especially with the lightweight cases they're now being sold with. And you can also play with the magnification. So there's different, it's not just a 20D lens that you can use. You can use a higher mag lens or a lower mag lens to get the appropriate field of the retina. And of course, the BIO generally provides wider field than slit lamp-based lenses. That's not always the case, but it can be, and especially if you're using a 90D lens, a more classic lens. And with a slit lamp, you're going to get less field than with a BIO. So a BIO is imperative for a true peripheral examination. Now, you have to keep in mind that it's an ethical and legal responsibility to perform regular DFEs even on asymptomatic patients. Undilated wide field imaging without dilation should never be offered as a universal option to all patients, as it's below the standard of care. Now, to be very clear, it doesn't mean you can't offer imaging to your patients. It simply means that imaging alone isn't enough for every patient. Now, the AOA and the AAO have recommended individuals with diabetes receive at least annual dilated eye examinations. A DFE examination is considered the standard of care. In fact, an optometrist can be legally liable if they fail to identify disease was present at the time of examination, but was missed because of lack of dilation. So imaging is not a replacement. Now, DFEs remain the best method to maximally and stereoscopically visualize the posterior segment compared to imaging alone from a legal, ethical, and clinical standpoint. If and when imaging is used to look for a suspicious lesion or anything else, dilation is still the standard to further evaluate and accurately diagnose the findings. So I sometimes find imaging is very useful as a preliminary thing to get a big map of the retina, and then you can hone in with your BIO to really look at the area. So I find imaging, I don't want anyone to misunderstand the presentation. Imaging is very important and very relevant. It's simply that you must verify it with traditional techniques such as BIO. Both OAO and the AAO recommend stereoscopic microscopic examination of the macula. Recommendations for dilation are every 1 to 2 years after the age of 65 to catch subtle signs of AMD. AMD patients may require dilations at even closer intervals, depending on the severity and the specific condition. According to the AOA, BIO with pupillary dilation is generally necessary to diagnose a peripheral retinal break or detachment with scleral depression if indicated. The AAO's preferred practice pattern specifically states that wide field color photography can detect some peripheral retinal breaks, but does not replace careful ophthalmoscopy for peripheral vitreoretinal disease. So in conclusion, I guess the entire presentation can easily be summarized that imaging is not a replacement for dilation. Imaging and BIO work best in concert, and I'm never one of these ideological people to pick one school of thought or another. Why shouldn't we use both techniques? So keep in mind my special tips for avoiding trouble in practice: dilation, documentation, and communication. And with that, I will hand it over to Kristen.
Thank you, Mark. Thanks very much. That was very informative. Lots of good content there. I see we have a couple of questions, which we will get to shortly. What I want to do is take a couple of minutes just to go over the HEINE Omega 600, and maybe in turn you can apply or provide some clinical feedback on some of the features that we have in our indirect ophthalmoscope, and maybe some features that stand out to you in your clinical setting, that have helped you with,
Sure.
your patient care. So the Omega 600, and to start, some of you may be very familiar with HEINE. You may have used HEINE in the past or currently in your clinics or clinical setting. We have been manufacturing indirect ophthalmoscopes for over 40 years, so dating back to the Omega 100. And fun fact, we still see a lot of those in Canada. So there's a lot of the Omega 100s, 150s, 180s, and then the 500 was the model before the Omega 600. So this was launched 3 years ago. It was a complete redesign, so a completely different looking product. And we had a few goals in mind in designing and manufacturing this product. And they were to build and make the lightest weight BIO on the market as far as a premium or high-end binocular indirect ophthalmoscope, one that was the most comfortable. So again, weight and comfort go hand in hand. So ergonomically, very well designed. Also, an indirect that provided the best retinal views in any clinical setting or any patient setting. So depending on abnormalities, conditions, you would still get the very best image of the retina with ours. And then something that's intuitive and very user-friendly. So some of the big changes in the design are by far the weight. I'm sorry, I have to stand back here a little bit. One big change that we made was to redesign the battery. So if you can see that, this is the battery weighing 21 grams. So for those of you that are familiar with the Omega 500, you may remember that the battery was on the back of the headband. So that has drastically reduced the weight, sorry. And in turn, we are actually 20% lighter than our closest competitor on the market. So as far as the ergonomics and the comfort, obviously being less weight makes it more comfortable, but also we remained, we kept this feature, which is the articulating hinge. This just allows, you know, any shape of head, any size of head, you can customize this so that it can sit below the occipital bone, for example, for the most comfort when wearing the BIO. As far as looking at the retina and having the best optics, and Mark, you touched on this as far as a peripheral exam. One feature that we have in our optics, which is just below here, and it's our stereoscopic adjustment technology. Essentially, it's a small pupil feature. So allows you with this lever, it's variable. So from 10 millimeters all the way down to 1, you can get into a very, very tiny pupil, as small as 1 millimeter. Okay. You will still see a very stereo image, so 3D image in that small pupil with this lever, with the help of this lever. So if you have patients that are very small in their pupil diameter, or they can't be dilated, this is a nice option to have. It's important to note as well that it's not a fixed system, it's a variable system. So it's 1 millimeter through to 10. Okay, so you're not compromising the stereo image or the field of view with this lever. We've also added a new tool or function called the Vision Boost. And this is the illumination. This is your rheostat or on off. This allows you to safely increase the illumination from 100% to 245%. So what it does, it gives you a blast or a boost of illumination, to get through any type of cataract or opacity. So in patients with cataracts, it can be tricky to see the retina. So this extra light just gives you a little bit of a boost of illumination to see the retina through the cataract. And studies have shown that there's 20% better view when using this feature or function on patients with cataracts. So those are some of the things that we've changed, namely, you know, obviously the weight, the comfort, it's quite a bit lighter weight. So I don't know, Mark, from your perspective, if you have found any of those features to be beneficial on a clinical side, perhaps with your patients, you might want to add to that.
Absolutely. Well, first of all, I can say we were just talking before the webinar, and I don't want to sound like a dinosaur, but I think we've known each other for almost 25 years. I got my BIO probably my first year of optometry school. And in fact, I still have it and I use it. And it was I think it's called a Sigma 150 at the time.
Yes.
And it was super lightweight. You know, I had a smaller PD, so I needed that model. And it's still working fine. It's beautiful, lightweight. I still use it in clinic. Of course, when I got the Omega, it was like, wow, I thought there was nothing in the case because it was so light. So that's definitely a change, especially for the premium product. When I had gotten my Sigma, this was like the kind of the not the latest model at that time. So it was for a lighter design. But absolutely, the weight is a big thing. The battery pack is now smaller than what I would think is a cell phone battery. So it's like a teeny tiny little thing that you click on the side. So you don't even feel it compared to the battery packs of old, even the portable one. So now it's like nothing, and it keeps its charge pretty well. I love that magnetic cover that protects it. You kind of think, well, that's a small thing, but it's not, because if you lose that cover, it's annoying. You know, your equipment can be damaged. So it's good to have something that won't fail you. And the optics, obviously, they were always great. So there's no real, you know, I don't have to say much about that. And the entire experience is great. It's comfortable, and I have a smaller head again and smaller PD, and I don't find it a challenge like it used to be to be able to perform. And now on the I would say the students are spoiled now because everybody can fit in the premium model where, in the days of old, you had to have a certain head shape or, the PD had to be in a certain range.
Yeah, that's true. And the PD, I didn't mention that, but the PD on this is also 46 to 74 millimeters. So again, it's a wide range covering all various PDs, interpupillary distances. So very good. Excellent. I think we have a couple questions.
Sure.
And if anyone else has more questions, please feel free to put it in that chat box. And I think these are directed to you, Mark.
So I can read them out if you'd like.
Okay, sure.
I already caught my eye, the first one, and I think it's from Dan. It says, "What's the lifetime probability of getting sued as an optometrist practicing in Canada?" Nobody gives me a straight answer. Well, that's a great question, Dan. I think the reason why people aren't giving you an answer is because they may not know. I don't think it's particularly high. I think it's quite low in Canada versus the United States. There are some barriers to litigation, which is the cost. So a lot of these cases, a lawyer has to, vet them and think they have some kind of merit to them, and also that the costs are worth actually going forward with it. So the idea of what are the chances of being sued, it's not, we'd like to think as doctors or even students that if you do something bad, that's where you're going to be sued, or if you don't do anything wrong, you'll never be sued. That's just not the way life works. As we all know with everything, that's not reality. So all you can do is do your best. Like I said, use my 3 points to dilation, documentation, communication. And will that work in 100% of cases? No. Some patients just won't, will be disagreeable no matter what you do. Will suspect that something was your fault, even when it wasn't. With maybe if I can give another tip for patients who are at risk of retinal detachment, I always tell them, even though I checked you today, because of the nature of this condition, you could detach tomorrow. The retina could break tomorrow. So just because I checked it today, I don't want you to have a false sense of security if you still have symptoms or they worsen tomorrow. So I need them to understand that it's a dynamic situation. So again, you can do your best, and the truth is there'll be that one person, and it doesn't matter if they went to your office or another office, who will be upset no matter what and who will potentially pursue a case. But then the good news is many lawyers will not take a case that has no merit because, of course, it's their professional reputation as well. And there's no way to, have a victory in court on that particular case. But I'd say that the risk is low, but it's not zero.
Very good. And then the next one is from David Ferguson. Can you elaborate on your preferred BIO lens and for which circumstances you use such? Thank you.
Right. Well, thank you for the question. Really appreciate it, David. I have to admit, I pretty much use the 20D lens most of the time. There are other lenses, but I haven't, delved into that particularly. But you can get more magnification if you want. You can get less magnification if you want. There's all kinds of new lenses that are being made that work perfectly in concert with the BIO for a clearer image as well.
Very good.
Sorry, go ahead, Kristen.
Oh, considering the advancements in technology, will HEINE be incorporating a small pencil type of camera in the BIO to take fundus images? Ooh, that's a good question.
A great question,
yeah. So right now we actually do have a camera. I don't know, Lou, sorry if you're familiar. We do actually have a video indirect ophthalmoscope. I'm not sure if you know that. Now it's not, I wouldn't consider it small. So it is a camera that is attached to an indirect. So it's not small and say portable, but we do have the digital capability of recording a fundus exam through an indirect ophthalmoscope. So we do have something. Will we be coming out with something in the near future? I don't know the answer to that, but that's something that I can certainly look into for you. I know that at HEINE, we do have a lot of investments in digital technology and we are taking it quite seriously. But at this time, I can't tell you if it's coming or not, but I will certainly, I can get your contact information, and it's something I can look into for you and provide you more information at a later date if that would help. But a very good question. And at the same time, if you didn't know that we have a digital indirect ophthalmoscope, I can also send you information on that, our current product. Hopefully that helped answer your question. Any other questions? Does anyone have anything else to add? I don't think so. Okay. Excellent. Oh, I do have another question. Does the newest HEINE operate on battery only? My present HEINE physically plugs. Okay, yeah. So the Omega 600 is battery powered. Yes, so it is that little mini battery that goes, it's a lithium polymer battery. It's charged via USB-C or a wall charger. Is that your preference, Mark, to have a battery option? That's definitely our most common, is to have a cable-free or wireless option. And with technologies and charging like USB-C now, it's so easy. You can charge it really anywhere.
Yeah, I mean, I totally don't want the wires are annoying when they're in the way, and I kind of have to put it behind my ear or do something so that it's not intervening. But I guess one thing you could do is have a spare battery, right? You could, if you have a really busy, I think it would last a day anyway, but if you had some kind of incredibly marathonish.
The other thing with our system is that we have a visual indicator, so a battery level indicator, so you always know the state charge of your battery. And I'm going to say most MDs, ODs using our product will say they get at least a week out of a charge, and if not longer. So it's not something that you have to charge every day. You know, it's only on for whatever, a minute, if that, per patient. But because you have that battery level indicator, you're always going to be with a charged battery. You'll never have a battery just die, because once it gets to that orange light, you know you need to charge. And it only takes an hour and a half to charge. So you get 8 hours of on-time use, 1.5 hours to charge. So I think the battery technologies this day are so sophisticated that you really don't have to worry about, you know, a battery dying randomly or sporadically. And because we have the visual cue or the indicator, that's really helpful as well.
Yeah, it's a huge
Mark,
difference.
feel free to reach out to us as well. I don't know if you're from Canada or the US, but obviously you can email heine.com. We have a customer service, like an info chat there. Sorry, an info email address, but also Mark and I are both on LinkedIn. So yeah, if you have any questions, please feel free to reach out there as well. And we have another question. Can an optometrist be liable if a patient refuses to get dilated? Ooh, that's a good one.
That's a really good question. In fact, it's interesting. A colleague asked that, a few days ago. Here's the reality. Anybody can sue you for anything. That's just how things go. However, the question of whether they'll be successful is a different story. So you can't stop someone from trying to pursue you in court, but the issue of whether they, if the patient refuses dilation, generally speaking, courts will side with the optometrist or the doctor in question if it was well documented and it seems like it was done in good faith. Of course, there can be questions as to whether they were properly informed. These are generally the issues that are brought up, but that's just the nature of the legal system. You know, they'll try to see if there was another angle to this. But of course, a patient can say, I was never told, the doctor never offered it to me. But generally speaking, if you document properly, you're safer than you would be otherwise. So anything's possible, but I wouldn't worry about that. But that's like saying, I took every precaution in whatever activity I'm doing. Could something bad still happen? It's possible, but there's nothing more you can do. That's really the limit of what you can do. And I don't think that you need to take things to an extreme. I know some of my colleagues will say, like they'll really try to push, because remember, in I'll say most jurisdictions, probably all jurisdictions, but we'll say most just to be safe, that the patient has a right to refuse any treatment, any diagnostic procedure, and you can't kind of influence them beyond, put pressure on them to do something if they do not want to do it. Now, you can explain to them the risks and the benefits, but you can't impose a certain procedure on them. So you have to be careful, because after you've explained things, you just have to make sure they understand, and then you document it in that way, but you can't really push them to do something they don't want to do.
Mhm. Very good.
Good question, though. Thank you, Jennifer. I see another one. Kristen, do you want to read it out, or should I?
Yeah, sure. Can dilation be used if a doctor is not present in the office? Do the offices using dilation need to have a crash cart?
Okay, so I mean, I'm just going to tread carefully on this one, just because it's more of a jurisdiction dependent question. So I will say that it really depends on the rules in your jurisdiction, on what can be delegated to someone who is not the doctor, and whether they need direct supervision or indirect supervision. So, and that's again, loosely speaking, about what many jurisdictions will define it as, whether you need a doctor present to do something in an office, or whether you don't need a doctor present to do something in an office. And so this is very jurisdiction dependent. So it really depends on where you are. There's some jurisdictions where you can't even say to a patient, if there's an emergency, go to emergency. You have to have a backup plan in your office. So there's a spectrum of different kind of rules on this. So it really is jurisdiction dependent. You'd have to look up the jurisprudence in wherever you're practicing, what province and state that you're practicing.
I think that might be all the questions.
Perfect.
All right, so I guess to conclude, again, thanks everyone for joining us. It was great to have you, Mark. Your presentation was super informative. And again, thanks for your time. Appreciate it. Take care.
Take care.